GECO meeting. And today we have 33 registrations from 9 countries. Of course, GECO is hosted by the GI Foundation in association with Project ECHO, University of New Mexico. And of course, they're held weekly on a Wednesday. And the chat will be open for any questions that you may have. So I'm going to kick off today's session with Professor M Setshedi, and she's going to give us a little overview of thalidomide as an option in the treatment of inflammatory bowel disease. So I'll hand over to you, Mash.
Right. Good afternoon, colleagues. I hope you can hear me and see my slides. Can you please confirm that, Jill?
Yes, Mash, we can hear you and see your slides.
Okay, fantastic. So we have briefly discussed thalidomide here and there, but not formally on this forum. So we thought that it's an opportune moment to discuss it, because I think it's an interesting topic and something that we need to be aware of. So we've entitled it Thalidomide, an option for the treatment of IBD. So we all know the notorious history of thalidomide, which is an antiemetic as well as a sedative that was used by women in the 1950s when it was brought onto the market for pregnancy-related nausea. Unfortunately, it turned out that it was probably the most teratogenic drug ever released on the market, with 10,000 children having a limb as well as intra-abdominal abnormalities. So ultimately, in the 1960s, this drug was taken off the market, received a lot of negative publicity. However, in the interim, scientists in the background were working on trying to understand the mechanism of action of this drug, and in fact uncovered some of its anti-inflammatory properties. As a result of that, in the 1990s, the FDA approved the drug for erythema nodosum leprosum, which is really an autoimmune complication of leprosy. And then because of that FDA approval, more studies were undertaken in an attempt to understand the mechanism of action of this drug. And as a result of that, the drug was approved again with very strict control by the FDA for the treatment of multiple myeloma. Subsequent to that, there have been many off-label uses for the drug listed there, including Crohn's disease. So how does it work, and why would it work in these autoimmune disorders? It's because it's got broad-ranging anti-inflammatory, anti-neoplastic, and anti-angiogenic properties. In this audience, I don't need to convince anybody of the central role of cytokines in the pathophysiology of inflammatory bowel disease. So I'm not going to go through that. But the molecule itself, thalidomide, it's a glutamic acid analog, and it has 2 enantiomers. So enantiomers are structures of a molecule that look identical in mirror image, but you cannot superimpose them on top of each other. So it has the R enantiomer, and this is the one that binds to the sleep receptors and is directly responsible for the sedative properties. And then more relevant to our talk today, it has the S enantiomer, and this is the one that has anti-inflammatory properties because it directly binds to tumor necrosis factor here at the monocytes, thereby inhibiting the release of Th1 cytokines, inhibiting T-cell resistance to apoptosis, inhibiting angiogenesis. It also slants the immune response more from a Th1 response to a Th2 anti-inflammatory response. It also inhibits a nuclear factor kappa beta with downstream effects, but also importantly, it is an anti-integrin. So these are the mechanisms by which thalidomide would work in IBD as well as the other immune disorders. So in terms of the evidence for use in IBD, well, it has to be said that the evidence is quite scanty. So in the 2009s, there were 2 Cochrane reviews. They were aiming to review the use of thalidomide in IBD. In their protocol, they wanted to include only randomized controlled trials. Unfortunately, both studies failed to come up with outcomes because there were no RCTs that were eligible for inclusion in the study. Moving on about 7 years later, in 2016, there was a systematic review, again trying to look at the use of thalidomide in IBD, so safety and efficacy. And here they were only able to find one randomized control study and 10 case series. Because of that limitation, they were really unable to report on some of the outcomes. The most successful study and systematic review on this topic is one done in 2016 by Bramuzo and colleagues. And here their aim was to include most of the studies. So they found 2 randomized controlled trials and 29 uncontrolled studies with a total of 489 patients. They took all study types excluding single case reports. These studies included children and adults at all the ages. They included all forms of inflammatory bowel disease in patients with moderate to severe activity, and particularly patients who were refractory to standard or conventional therapy, as well as biologic therapy. The dose of thalidomide in the study varied from anything from 50 milligrams to 40 milligrams at night in adults, and then 1.5 to 2.5 milligram per kg per day in children. These patients were on thalidomide with infliximab or adalimumab, or thalidomide with cyclophosphamide. And then they reported on a variety of outcomes listed there, which I will show you. So the study cohort was 489 patients. And what you see is that the majority of patients in these studies had Crohn's disease, with only about 10% having ulcerative colitis. Most of the patients were adult, so 55%, and with about a third being under 18, and then smattering of other ages or not reported. Most of the patients were male, with about 40% female, and in 13% this data was not recorded in those studies. If you look at the results, they looked at several things. The first was the efficacy of thalidomide in inducing a clinical response or remission. And these are all the studies that we included in the systematic review. And what you see is that the clinical response rate was 75%, and the clinical remission rate was 53% or 54%, which is pretty good. And then they looked at maintenance of clinical remission in the long term. And what you see is that over time, the effect actually lessens. So at 6 months, the effect was 80%, reducing to 72% at 12 months. And then another year later, being about half the patients being in long-term remission at the 2-year mark. So there is loss of response over time. And then if you subdivide the response by the type of Crohn's of IBD, you can see that in general, the response rate was better than the remission rate. And this was more so marked in patients with ulcerative colitis than in patients with Crohn's disease. So patients with ulcerative colitis tended to have better response rates compared to Crohn's, but overall response was better than remission. And this actually has been mirrored in many, many other studies that have reported the use of thalidomide in IBD. And then if you look at, yes, so I've covered that. And then in terms of the reduction of steroids or suspension of steroids, again, you can see that in about 152 patients, they were able to reduce the dose of steroids or completely stop steroids in about 70% of patients. So they did have some steroid-free benefits, which we know is a good thing because you don't want to keep patients on steroids for long periods. What was the response on fistulizing Crohn's disease? The population was quite small, only 81 patients, but there was improvement in the drainage of fistulae in about 60% and a complete cure in just over a third, which again is really not unreasonable efficacy rates for this drug. They then looked at endoscopic remission, and similar to clinical remission, the response rate was better than the remission rate, but still above 50% for remission and about 70% for response. And then I think really the value of this agent may be in patients who have failed biologics. Again, small study numbers, but what you can see is that in these patients who have failed biologic therapy, 65% had a response and 50% had a remission. So it compares favorably with the other agents that are on the market. Of course, the main problem with this drug is the adverse effects. So here in this table, I've recorded the adverse effects recorded in the systematic review. And what you see is that 338 patients experienced about 530 adverse effects, but this resulted in a withdrawal of the drug in about a third of patients. And by far the commonest side effects were neurologic, occurring in about 64% of patients. There was a whole range of neurological adverse effects. I've only depicted here the really important ones and the ones that are reported on in the literature in the case reports. So peripheral neuropathy was quite high, with about half the patients having to withdraw the drug. As I've shown you, the mechanism of the drug is that it's a sedative, so it's not surprising that a quarter of patients had a sedation. And then the next commonest side effects were cutaneous manifestations, so patients had dermatitis, seborrhea, xerostoma, etc. In terms of the gastrointestinal side effects, 10% of the patients had constipation. The most serious side effects, I would say, were the hematologic side effects, with the increased risk of deep vein thrombosis and pulmonary embolism. However, in this study, this was only reported in 2 patients. And the important note to make here is that thalidomide on its own right perhaps does not have such a high risk for thrombosis. This, however, is common when thalidomide is combined with other immunosuppressives, for instance, steroids or another immunomodulator agent. In that case, then the risk of thrombosis actually goes high. So even in this population of patients with IBD that we know have got a high risk of thrombosis anyway, the drug in its own right didn't seem to have a very, very high risk. Other hematologic disorders were bone marrow suppression and infections and so forth. Other side effects ranged from arrhythmias, there were ocular manifestations, amenorrhea, infertility, and other sort of non-specific complaints such as non-cardiac chest pain, dyspnea, etc. So the problem really, which I think is the rate limiting step with this drug, is the invariable development of side effects in most patients, and as I'm showing here, necessitating withdrawal in about a third. So subsequent to that systematic review that I've shown you, there actually has been only one other systematic review, and this one was looking at the use of thalidomide in the pediatric population, which I'll show in the next slide. But since this, there have been sort of newer expanding indications for thalidomide reported since that 2016 systematic review. And you can see that there seems to be some evidence that thalidomide can induce mucosal healing in the post-operative recurrence of Crohn's, but also that it can be used for de novo Crohn's disease after ileal pouch anal anastomosis. So now one is seeing more case reports as people are using it more, but still not enough to amass enough data to conduct another systematic review. And certainly there's no RCT in sight yet. I even checked the clinicaltrials.gov website. There aren't any ongoing clinical trials, RCTs on thalidomide at the moment. And I suspect that's probably got to do with the fact that we've got a whole range of other medications after anti-TNFs that we can use. And so I think, I'm not sure that we will be seeing an RCT anytime soon, especially if you compare the use of this drug against the side effects, which are not small. So this is the systematic review that I was telling you about that was conducted in children and adolescents, because up until this point, because there was no data, it was certainly not recommended for use in children and the adolescent population. And the systematic review essentially came up with similar results as we saw in the systematic review in adults, that it improved a clinical response by about 60% similar, and then a remission in about 50%, similar to what we saw in the adult patients. But again, here, the majority of patients, about 40%, had peripheral neuropathy that necessitated withdrawal of the drug. So the side effects were showing up again, even in the adolescent and pediatric populations. So with that background, I thought it might be good to illustrate the use or the problems with thalidomide in an actual case. So for the next few slides, I want to thank Dr. Dave Epstein, who we know very well. He's the founder of IBD Africa. He practices in Cape Town, has a very large IBD cohort. And he tells me that in his time that he's been practicing, which is at least 25 years, maybe 20. Sorry, David, I don't want to make you sound that old. He's only managed 2 patients with thalidomide. And he kindly supplied this case of a patient that he's been managing with quite severe Crohn's disease. I myself have never managed a patient with thalidomide. We don't use it in our public service. And I believe it's actually not that easy to get a hold of, and it's not affordable. And I'll come to that a bit later. So this was a 31-year-old female patient who gave a history that her maternal uncle was diagnosed with ulcerative colitis at a very young age of 13 and ended at colectomy at the age of 21. The patient herself now, at the age of 7, was diagnosed with Crohn's colitis with fistulizing a perineal disease. At the age of 9, she required a diverting colostomy because of the severity of her perianal disease. At age 13, again, because of progression, despite ongoing medical therapy, she required a colectomy with a retained rectum and end ileostomy. She seemed to be well between the ages of 13 and 21, traveling overseas with her father, living her best life. But at the age of 21, she required episodic infliximab because of the disease remitting and relapsing nature. A year later, I'm not sure what the reason was. She was switched to regular adalimumab and seemed to be fine on this agent. So the history of her medical therapy is a bit checkered, but we do know that there have been courses of steroids. She's had azathioprine, methotrexate, she's had cyclosporin, as well as antibiotics intermittently. Again, I think speaking to the severity of her disease and the difficulty in managing and controlling her disease. So then at the age of 23, unfortunately, she developed disseminated TB while she was on adalimumab. At this stage, they were in the United Kingdom with her family. She was admitted and required ventilation with a prolonged ICU stay. She developed critical care neuropathy. She also developed rifampicin DILI. And then because of her surgeries, she also required a laparotomy for adhesive small bowel obstruction. The fortunate thing, however, is that at this point, her Crohn's disease was quiescent while she was on TB treatment. And then 2 years later, she presented again in the UK in Oxford with recurrent perianal disease. She had a protectomy. She had non-healing perineal wounds, which required quite extensive management with vacuum dressings. Her infliximab was restarted. So remember, she had been on adalimumab. So her infliximab was restarted with INH prophylaxis. Unfortunately, she developed an infusion reaction. So I suspect that this might have been the reason for the stoppage of the infliximab the first time around. At this point, she was switched to adalimumab, 40 milligrams weekly, but was still struggling with her perianal disease, requiring regular EUAs and debridement and local steroid injections. So at this point, they returned to South Africa, and this is the point at which she was seen by Dave Epstein. So in 2014, at this point, she was still on adalimumab, 40 milligrams weekly, but because of her surgeries and her perianal disease, she required large doses of narcotic analgesia. So she had severe pain, couldn't sit down, had discharge. However, the ileostomy seemed to be functioning well. She had evidence of lung disease as a result of her TB. She had all the complications of malnutrition and severe Crohn's disease with osteoporosis, a low BMI, and then she had a large perineal wound. I've just put there that for those of you that are particularly sensitive, the following pictures are really quite graphic. So do turn away if you must. So this is how her perineum looked when she first consulted with Dave Epstein. You can see just how severe and dysmorphic and terrible really the disease is, and you can imagine what her quality of life would have been. Her labs showed a CRP of 15 with a normal albumin, albeit her hemoglobin was normal. She in fact was iron deficient. She had a hemoglobin scan, that's a discussion for another day. She had endoscopy via stoma, which showed a normal TI, and the biopsies from the perineal tissue were consistent with chronic ongoing inflammation with granulation tissue and granulomas, but there was no malignancy. The TB cultures and the ZN stain were negative. She had an MRI which showed that there were no collections that needed drainage, and her small bowel was normal. Her trough level was 5.2 with no antibodies. At that point, she was managed by a multidisciplinary team, so with psychologists, a psychiatrist. Her adalimumab was continued. She was then started at this point on thalidomide, 150 milligram at night because of the severity of her illness and because she had already cycled through infliximab and adalimumab twice already, and we know she had had previous courses of immunomodulators. She was responding well to the extent that it was possible to stop all her analgesia that she was dependent on. And in fact, she felt so well that in 2016, she herself decided to stop her adalimumab because she and her father felt that it really had not made any difference to her perineal disease, and she was doing well and thriving. So again, here you can see how she was at presentation, and you can see that there's really a big improvement in her perineal disease. Unfortunately, in 2017, she had a loss of response to the thalidomide at 150 milligrams. She was acquiring narcotic analgesia again. So as a result, after consideration of the possible side effects, etc., her dose was escalated to 250 milligrams at night. And then a review of her medication was done, and the history of why she had been on methotrexate and why it was stopped was not clear. So as an add-on, it was decided that she should be started on methotrexate, escalating to a maintenance dose of 25 milligrams weekly. Unfortunately, she developed complications on that methotrexate. Remember, she was also on on thalidomide and I think at that stage adalimumab as well. So she developed quite severe sepsis with neutropenia, a respiratory tract infection, but fortunately, with withdrawal of the methotrexate and the antibiotics, she responded to treatment. And the thalidomide was ultimately stopped as the high dose was not effective after 4 months. And the issues of toxicity, as I've shown you, were becoming a concern. In 2021, at that point, she seemed to be stable clinically, as well as biochemically, with a normal stool calprotectin, normal MRI, no positive cultures of TB, and her other labs were essentially quite normal, and she was doing very well off the methotrexate, off the thalidomide. Unfortunately, she relapsed, and the thalidomide was restarted at the dose of 250 milligrams. And this time, after much discussion, it was decided that they wanted to add ustekinumab. So currently, she's on ustekinumab, and at that stage, they were thinking of other modalities of therapy, and she was being considered and worked up for an autologous bone marrow transplant. Unfortunately, in that process of being worked up, she developed TB again. So at this point, as far as I understand from David, she is off thalidomide, she is off ustekinumab, she's not on any specific therapy, and it's an ongoing struggle to manage her Crohn's disease. So, I mean, to say that this is a stormy, tumultuous course would be an understatement. I think this case just shows how difficult it can be to manage patients who present with pediatric onset fistulizing disease. She's got a family history. So I was wondering whether she's looking more like a patient with a monogenic IBD and whether anything can be done to investigate that. So in terms of the practicalities of prescribing thalidomide, should you find yourself in that situation, you need proper signed informed consent, not just about the side effects, but about the drugs, the possible loss of response, the complications, etc. So I think you really need to have a discussion with the patient, the family, and make sure you're all on the same page and document everything, really not to be taken lightly at all. At the time of starting, you need to ensure that the patient is not pregnant, and the guidelines are that you need to use 2 pregnancy tests. So the pregnancy test has to be negative twice. And then you must advise the patient on very, very aggressive contraception, ideally 2 contraceptive methods, while the patient is on therapy and for some time after the therapy has been stopped. You need to try and use the lowest effective dose possible. So as I say, anything ranging from 50 milligrams up to 200 to 250 milligrams at night. Because of the sedative effects, it is advised that you prescribe the medication once a day at night. It goes without saying that you have to monitor the patient continuously for adverse effects. Some authors suggest that you continuously monitor thyroid function, obviously, and the other stuff that I've mentioned. Cost is a factor. So whereas this drug used to be dirt cheap, up until it was repurposed and reapproved for those indications, it has become exorbitantly expensive. So one tablet of thalidomide in South Africa costs $150. So if you're going to prescribe it at 50 milligrams at night per day for a year, you're looking at a cost of about 45,000. And if you're prescribing at the dose that this young lady was on, of about 200 milligrams, you're looking at a cost of about 400,000 per annum. That is not cheap. And we don't have generics. We don't have it available in the public sector. It's not easily available in the private sector either. There are thalidomide agonists, lenalidomide, which is, I think it costs 2,000 or 3,000 per tablet. So that's clearly unaffordable. Those are supposed to have fewer side effects. But also there aren't enough studies on the thalidomide analogs for one to make any assumption about whether they work or not. And then wherever you can get thalidomide, registration of the drug and of use by the clinician as well as the patient is very, very important. So there's a program called STEPS. So this ensures compliance, education, etc. So you need to register the drug with the STEPS program to make sure that things are done right. So this is my last slide. I think there is evidence for off-label thalidomide in IBD, and I think evidence is accumulating, although the evidence is weak, as I say, because we don't have any RCTs, and we certainly, I don't think we'll have head-to-head studies. It appears to be valuable as a treatment option for patients with IBD who are refractory to first-line as well as second-line therapies. So in a case like this where you're struggling, it certainly is an option. The problem, of course, is that there is a bit of a loss of response, but that's in about 10–15% of patients. The biggest problem are the adverse effects, where the drug has to be stopped or the dose reduced. I've shown that the response and remission rates are similar to other drugs, as well as to patients who are naive to biologics. I think more studies are needed, but I'm not sure that it's going to be possible to do those studies realistically currently, given the armamentarium of drugs that we have. I think that is my last slide. Thank you for your attention, and I'm happy to take any questions.
Thanks, Mash. That was an excellent overview. Very impressive, actually. So there aren't any questions from the fellows, but just a comment really, how tragic it is that a drug that's been around for over 50 years and was dirt cheap, that somebody's making a hell of a lot of money off it. I think it's just so unethical. Yeah, it's really tragic. Just to all the fellows from Sub-Saharan Africa, if you could just post on the chat, or if you'd like to speak in person, do you have access to thalidomide in your countries? I think most people are probably a bit shy, so you can just post it into the chat then. Okay, Mash, I think in the interest of time, we should probably move on because we ran over a little bit. Would you like to introduce Esme?
Yeah,
oh, yeah.
Okay. Thank you, Prof.
Hi, everybody. I guess you know his name by now. He's one of our fellows in our unit here at Grooteskier, and he's going to present a case that we managed around the time of SAGES. Take it away, Yasmin. Thank you.
Okay, thanks, Prof. Hi, everyone. I'm Isnin. I'll be presenting Mr. JFRF. He's a patient who was admitted very recently to our center. He's a 25-year-old gentleman who was known to have ulcerative colitis, pancolitis, who was diagnosed in 2014. Initially, a patient was diagnosed in 2 military hospitals, and patient was on sulfasalazine and had multiple flares during the first year of diagnosis, which required multiple doses of courses of oral steroids. And in 2016, after the funds ran out, he had defaulted. And at the end of 2017, patient had presented to WIC with acute severe UC and subsequently was referred to us. This was in 2017, and he had got IV hydrocortisone for 3 days and received 1 dose of rescue infliximab at the end of 2017. And he responded quite well to the infliximab during that time. And he was started on azathioprine, but developed a urticarial rash. And we opted to give 6 MP at 125 milligrams daily, and patient was doing well with that. However, unfortunately, his last follow-up in our clinic was in 2018 November, and apparently he defaulted his medication for the last 4 years, and he says he had 2 minor flares which resolved on its own. However, he presented to Victoria Hospital again on 1st of August, with bloody diarrhea, more than 10 episodes per day for the last 2 days, with generalized abdominal pain. And on arrival, his temperature recorded at Victoria Hospital was 37.9, heart rate of 121, and a CRP of 320, and a ESR of 34. And his hemoglobin was 12.4. So by True Love and Wits criteria, this fits the diagnosis of acute severe UC, and patient received 2 doses of hydrocortisone at Victoria Hospital and a stat dose of ceftriaxone and metronidazole, and was referred to us. So on day 1 at arrival, patient's heart rate was 80 per minute, BP and other vitals were stable. Patient abdomen was soft with generalized tenderness, noted more on the left iliac fossa. There was no rebound tenderness. And we did a flexible sigmoidoscopy on arrival. And as you can see, there's a severe erythema, and the patient was bleeding spontaneously, and there were multiple ulcers, and we did a flexible sigmoidoscopy just to 40 centimeters, and it showed a lot of ulcers here with the background of erythema and multiple pseudopolyps as well. So we admitted the patient, and we sent out the routine bloods and blood culture, which came out negative. We started the patient on IV hydrocortisone, 100 milligrams every 6 hourly, and ceftriaxone and metronidazole was continued, and IV hydrocortisone and Clexane. And these were the labs on the first day. You can see the hemoglobin was 13.3. The significant findings were a high CRP and a low albumin of 25. And stool had 3 leukocytes, 3 erythrocytes, and CD4 was negative. And this was the abdominal X-ray, which was done on the first. And it's just, there was no sign of transverse megacolon. There was just fecal loading on the right side. And the histology, there was no, it was just chronic active colitis, which was on the histology, and there was no CMV seen. So we continued the patient and on hydrocortisone, and on day 4, so we completed 3 days, and it showed that patient still had blood mixed stools, around 6 stools per day, and he did have abdominal pain, and there was a mild left side tenderness, but it was not peritonitic. Abdomen was soft. Heart rate was 72 per minute, and CRP was 96. So at this time, we decided the patient to give infliximab, and we did inform the colorectal surgeons regarding the patient, and who was seen at the same day. And the labs showed that there was mild anemia with a high CRP of 96. Otherwise, the renal functions were fine. So what we use is the Oxford criteria by the end of day 3 to see if the patient is responding to steroids. So this is the first one, is the Oxford criteria. And then we have other Scottish index and other criteria as well. So the Oxford criteria states that if the stool frequency more than 8 per day has a high chance of treatment failure, or if the stool frequency is between 3 to 8 stools per day with a high CRP more than 45, this means there's a chance of treatment failure in 85% of the patients. So our patient had a stool frequency, by the end of the fourth day, patient had a stool frequency of 4 with a high CRP of 96. So in these patients, the echo statement, they suggest either infliximab or cyclosporine should be used in adult patients with steroid refractory UC. So it's the construct trial which compared the two, which showed no significant difference at the end of 12 months for rate of colectomy or improved quality of life or mortality. There was one post-hoc analysis which showed a shorter hospital stay with infliximab. And on day 5, so this was after the dose of infliximab, patient's general condition was better. There was minimal blood in the stools. So the stool frequency was now 3 to 4 per day, and mild abdominal pain was present. However, there was no tachycardia and patient was afebrile. Per abdomen was soft, left-sided tenderness was there, but there was no rebound phenomenon. And on day 6, patient continued to have blood-stained stools. So it was 3 times per day, and the patient still had the abdominal discomfort, but he said it was now present only when passing stools. However, patient had a tachycardia of 102, so we decided to do a CT at this stage. So this is quite an impressive CT, and if you see the CT, there's a huge transverse colon measuring 88 millimeters across the diameter. So it was reported as complicated by a toxic megacolon at this point. However, there was no pneumoperitoneum or drainable collections. So at this point, we decided to give a second dose to salvage the colon. So we gave infliximab at 10 milligrams per kilograms. The first dose was also given at 8 milligrams per kilograms. Colorectal team, they actually reviewed the patient, and clinically patient was well. So we decided to see how the infliximab second dose goes, and stoma therapists had seen and then cited the patient for, yeah. So this is another echo statement which states that there's currently insufficient evidence to determine the optimal regimen of infliximab rescue therapy in patients with acute severe UC refractory to corticosteroid therapy. So there's no RCTs that compare the different induction doses. However, we know that acute severe UC has a high inflammatory burden with accelerated clearance and fecal loss of infliximab, which gives a low concentration and immunogenicity. And so infliximab concentration also affected by the low albumin levels, such as in our patient as well. And due to malnutrition and protein loss, so it's reasonable to initiate treatment with intensive dosing regimens. So in day 7, patient's condition was better. He had loose stools 3 times per day, and there was no blood in the stool. So the abdominal discomfort, it was mild, but abdomen was soft and non-penetrating. However, there's mild tachycardia, 98 per minute, and we requested a surgical review again, and this time we did the bloods. The HP was 10.8, and renal functions were fine. Albumin was 20, ALT/AST was fine at this point. So this was day 8. So the general condition was same as the day before. However, patient had loose stools 2 times per day, no abdominal pain. There was tachycardia 94.94 per minute, and abdomen was soft and non-tender. So it's much better than what it was at initial presentation, but you can still see deep-seated ulcers here with blood clots in the colon and loss of quite erythematous colon. And the x-rays are showing quite a large transverse colon here, and you can see a featureless colon suggestive of inflammation. So then this was the SAGES weekend. Unfortunately, we didn't have many senior doctors around that time. And so patient continued to have diarrhea, like 1 to 2 episodes per day. However, there was no blood. And IV steroids was changed to oral steroids on the day 9. And heart rate was in between 86 and 90 per minute in these 4 days. And we did repeat the bloods on day 12, which had a high CRP of 114. And on day 12 night, patient had multiple episodes of loose stools. It was very severe. So like once every hour, patient had to go to the bathroom. And heart rate was 90 per minute at that time. And this is the abdominal X-ray, which was done the next day morning, which showed quite a dilated colon. So it was measuring 85 millimeters. So it was day 14. There was no blood, but there was watery diarrhea 3 times per day. And patient had severe abdominal pain and had a tachycardia of 104 per minute and had spiking fevers. So finally, the decision was taken to do a subtotal colectomy and then nihiloscopy. During the postoperative period, patient had a high output stoma and with an ileus, which required TPN and received antibiotics for a suspected intra-abdominal infection. Otherwise, patient recovered and was discharged on day 16 post-op. Yes, thank you.
Thanks, Isneen. Jill, I guess you're going to go ahead immediately, right?
I am. Isneen, can you stop screen sharing?
Yes.
And I will attempt to screen share. I had problems earlier, so let's just see. Promising.
All good, Jill. It looks good. Thanks.
Is it? Okay, can you see it?
Yes, perfectly.
Excellent. Okay, so a year ago, I gave a presentation on this particular forum, which was called Common Mistakes in the Management of Acute Severe Ulcerative Colitis. So we decided to present this case, which was obviously managed in our unit, just to see how we're doing in terms of managing this. So acute severe ulcerative colitis is, of course, a medical emergency because of the risks of toxic megacolon and perforation, with very high mortality if inadequately treated. Historically, mortality rates of up to 75% at 1 year were reported. This was, of course, prior to the development of effective medical therapies. So the first breakthrough came in 1955 with a landmark trial by Trulove and Witz, looking at oral corticosteroids in the treatment of this condition, and decreased mortality from 24% in the placebo group to 7% in patients who were receiving steroids. And over the following 60 years, mortality has reduced significantly with timely surgery, intravenous corticosteroids, and obviously all the new drugs we have now. And in specialist units today, mortality rate is way below 1%. So we thought we'd look at the things that we did right. And there was quite a lot of things we did right. First of all, our colleagues at our secondary tier hospital were really on the ball. They got the patient to us within 24 hours of them presenting. They gave 2 doses of corticosteroids empirically, which is entirely appropriate. And the patient got to us, as I said, within a day of presentation. We sent off stool to exclude C. diff. We excluded CMV on a flexible sigmoidoscopy. These things have to be done because you cannot treat the acute attack adequately unless these are dealt with. We started venous thromboembolic prophylaxis. These patients are very thrombophilic and they are at high risk of developing a deep vein thrombosis or pulmonary embolus. And of course, as Isneen said, we assessed the severity of the attack with the Trulove and Witz criteria. He, in fact, had 3 out of the 5 Trulove and Witz criteria, and he also had a Mayo score of 3 on endoscopy, which is another marker of severity. So we continue to treat him with high-dose intravenous corticosteroids, which is the appropriate treatment. So just to point out, the number of Trulove and Witz criteria on admission is a strong predictor of the risk of colectomy. If you have 1 additional true love criterion, the 9% risk of malignancy colectomy. If you have 2 additional, 31%, and if you have 3, like he did, then you have around about a 50% chance of losing your colon on that particular admission. He also had an albumin of less than 30. Again, this is a predictor of colectomy on that particular admission. Some other things that we did do right is we got the colorectal surgeons and the stoma therapists involved very early. We identified that the patient was a steroid failure on day 3. Isneen has already told you about the Oxford Index. This patient had automatically failed steroids because he had a CRP of 98. And so we gave him the infliximab, which, as Isneen alluded to, is probably as efficacious as cyclosporin. And we elected to give an accelerated high-dose regimen. What would be very useful in this setting was if we had point-of-care therapeutic drug monitoring, which we would have been able to give us an idea of whether we had a properly therapeutic level. So what went wrong? Well, unfortunately, the surgery was delayed far too long, 14 days after admission. So why did this happen? Well, firstly, he was a partial responder. As Isneen said, his symptoms seemed to get better. His endoscopy, although it wasn't great, it certainly had improved significantly from the time of admission. So there's this automatic feeling to just push on a little bit longer and hope that you're going to get a full response tomorrow morning or the next day. And I think we're all guilty of doing this, because obviously having a colectomy and finally an ileoanal pouch, these are really life-changing surgeries. Isneen alluded to SAGES, and I think this was probably the major problem, was that everyone was so excited that COVID was sort of behind us and we could have an in-person conference, that all the senior staff, both colorectal and medical, took off for the Drakensberg, leaving our units rather understaffed. And I think this is something, a good lesson, and one that I doubt we will repeat in the future. Just some clues that we really had already lost this battle, and that this patient was almost certainly going to come to colectomy, was the fact that he had a persistent tachycardia and a persistent increase in that CRP, which suggests that there's a high inflammatory burden and a poor response to medical therapy. The colonic dilatation was also particularly concerning. If he'd had a toxic megacolon at the time of the initial presentation, then it's very reasonable to treat the patient medically for a couple of days to see if the colon decompresses, if there is no evidence of perforation. But very concerning that there was no colonic dilatation. And after 6 days of medical therapy, his colon then started to dilate. And it wasn't just minimal dilatation. This was a transverse colon diameter of 8 centimeters, so a good going toxic megacolon. So there were some other clues that colectomy was inevitable. The presence of abdominal pain. Ulcerative colitis is not associated with significant pain. This is unlike Crohn's disease, where the cardinal symptom is abdominal pain. Usually if they get pain, it's very mild, it's a left iliac fossa, and it's a bit like a dull ache. Severe discomfort is an extremely concerning sign. It suggests that there's transmural inflammation and the patient is at very high risk of perforation and may already have perforated. So that was very much an alarm sign in this gentleman. And you just must appreciate as well is that once high-dose corticosteroids are administered, the abdomen will be soft. It's unhelpful because steroids mask the signs of peritonism, and they also suppress the pyrexial response. So delaying colectomy is a problem. Medical therapy in excess of 8 days is known to be associated with significantly more major complications, in particularly corticosteroids and poor nutrition, which increases the risk, notably anastomotic leaks and sepsis. There is a twofold increase in hospital mortality if colectomy is performed after 6 days, and ours was quite a bit after that. No benefit in extending treatment beyond 7 to 10 days. So I guess it's not surprising that this patient had a complicated post-operative course with a prolonged post-operative admission. So we thought we'd just present this. We are a very high referral unit. We see a lot of acute severe ulcerative colitis. So even in a setting like ours, one can certainly see things like this happen, and just hopefully it'll be a lesson for us and for everybody going forward. Don't take your eye off the ball with these patients. And with that, I will thank you and stop screen share.
Thank you so much, Jill, for putting that together. And I think, look, there are explanations as to why this patient ended up at colectomy only at day 14. In fact, as Isneen was presenting day 5, day 6, day 7, I was thinking, goodness, this is just awful. So for the fellow, albeit there may have been reasons and explanations, I can say that the treatment of this young man was shocking, and we're actually very lucky to have gotten away with it. And I can say that because I was a consultant on call the week before SAGES. And because he seemed to be better, we carried on, but please don't do that. I think that is the lesson.
Learn from our mistake, please.
Yeah, no, just don't do it. Isneen, thank you so much for presenting the case so well, and also for adding tidbits of learnings. I think there's so much to learn from this case. So Jill, one of the major issues, other than that he seemed to be better and there was a partial response, etc., was that we were worried about him being operated on by a general surgeon, because we work so well with the colorectal surgeons who are specialists in this type of surgery, because this type of surgery is not like doing an appendicectomy. You know, it's specialized, you need experience, you need to know what you're doing. Do you think that was justified? Or in a situation where, for instance, there isn't a colorectal surgeon, then it will end up in the hands of a general surgeon. And
absolutely. Absolutely. I think the actual colectomy itself is not too tricky. It's the surgeries that follow that you really need a colorectal surgeon. So I think a general surgeon would have been able to take this colon out. I understand, you know, we're very spoiled at Criticare because we've got such fabulous colorectal surgeons that do all of this for us. But I think we probably were maybe risking things a little bit by waiting for our senior surgeons to return from the conference.
Yeah, it could have been handled by a general surgeon.
Yeah, I think so. A good, you know, experienced general surgeon.
Yeah, and that may well be the case in most hospitals that don't have it.
Exactly.
Yeah, I mean, I think the signs for a poor outcome were there from probably as early as day 3, definitely by day 5. There's no question. And then Joe, for the fellows, he had a lot of fecal loading, which I can explain in my mind, but sometimes the teaching is that if there's fecal loading in a segment of colon, that colon is probably not inflamed, which clearly is not always true, because I think 10% or 15% of patients with active flares constipation. So
yes.
Do you want to clarify that for the fellows, please?
Yeah, so I mean, when you look at an abdominal x-ray and you see where the feces is in the colon, it's actually a very good marker of where the extent of the colitis, because feces does not stay in very inflamed colons. So that's just, it's quite a good marker on an x-ray to see the extent of the disease. Does that answer it, Matt? I wasn't quite sure.
Yes.
Yeah.
I mean, I think that's what we're saying, that it generally delineate for you what areas are inflamed or not. But I think in him, that fecal loading was probably just a backup of stool, because stool.
Absolutely. A bit of a functional obstruction, just nothing working particularly well.
Yeah. Jonas Gedamu, I'm not sure which center you're at. Welcome. Your question is, how is the concern for latent TB flare when infliximab is started in your setup? I guess you're asking whether we're concerned. Yes, we are. So maybe he wants you to talk through what we do to exclude.
Yeah, so I mean, obviously it's a great concern in our center. And unfortunately, in the setting of acute severe ulcerative colitis, you don't have time necessarily to get tuberculin skin tests and IGRAs, and in any case, we don't have either of those available. So a single dose of infliximab, we're probably not going to be too fussed about that. But if we continue this patient on, they will automatically go on to INH prophylaxis in our setting, because we're at obviously very high risk just by being in our institution. Chris is on the call in private practice. I'm sure that he would have a very different take on that, and would certainly have IGRAs available, etc., and likely not treat empirically. Would that be correct, Chris?
Yeah, and then we put everybody on infliximab on INH prophylaxis, Jonas. Maybe just chat which center you're at. It would just be lovely to get to know people. Professor Cassinides, any comments or questions?
No, just that it's, you know, you've got excellent colorectal surgeons. We often even don't have dedicated colorectal surgeons, so we rely on surgeons that do the procedures routinely and commonly, but our general surgeons. And I think the importance is to introduce a surgeon into the management very early on, because then he doesn't allow you to subjectively and persuasively continue on this path, you know, of poor medical care. Although I think your medical care was exceptional. I think you're very hard on yourselves. There was a good outcome. But yes, I think having a surgeon counteract, when you feel you want to go for an extra day and you've got a surgeon there saying, look, I think we need to cut our losses, makes it much easier to manage. So introducing a surgeon very early in the management is absolutely mandatory in our practice.
Indeed. Are there any questions from the fellows? Isneen, do you have any other comments? I mean, just to note that post-op, just looking at the patient, he looked like a different man. So there was no question, and also the resected specimen, there was absolutely no question that that was the right thing for him.
Yes, we came back to our clinic. I think last week I saw him. He was quite happy with the colectomy, and he said he wished that the colectomy was done early on.
Don't we all?
But if I can make a point about extending medical care on and on with these newer agents, biologics that we've had, which have really made such a big difference to the management in the acute ulcerative colitis, that's one case, but we're also finding it in patients who are chronically ill and changing biologics and pushing the doses and not, pushing this surgery later and later and later, and then presenting presenting a patient that's ill, that's had 2 or 3 biologics, that's had number of doses of steroids, is becoming a big problem. So having access to more therapies is not actually making our lives much easier in that small group of patients that just are not responding to biologics. It seems in this biologic era that sending a patient for surgery is absolutely regarded as failure on your part as a physician and also in your medical care. So it is even a problem in that chronic setting.
Yeah, and the other thing I think is we have patients who on day 5, 6 will turn around. So they're slow responders as well. And you would have thought that experience would have helped us in this case to just know that this guy wasn't going to be that guy, but it's not easy. I mean, it just wasn't an easy call, because you also don't want to send people to colectomy when actually medical therapy could have worked. But sometimes you don't know it, like this case was a bit grainy. And I think Sages was
when you do send them the inevitable, when they come to see you afterwards, why didn't you send me earlier? Always. Yeah. When you introduce surgery to them, they are horrified and run a mile. When they've gone through it, they always come back and say, why didn't you send me earlier?
Well, retrospective vision is always perfect.
Exactly. And Mash, I'm sure as head of department, you'll make sure that there's always a senior person that remains behind at our conferences going forward.
No, indeed. I mean, I think, I think this certainly can never happen again. Not on our watch.
Absolutely.
We've got a minute left. I assume there aren't any questions. Jonas, I'm going to put you on the spot. You didn't tell us where you're from or which center you're at. If you're too shy to put on your camera, please put it in the chat. I really am curious.
And Mash, I also see Dominic did comment that they have access to thalidomide in Kenya in both private and public sector. So that's very interesting.
I see that, yeah. Jonas from St. Paul's Hospital, Millennium in Ethiopia, welcome. It's lovely to meet all of you.
Yes, fantastic.
Right, I am going to close this meeting. But before that, I am required to thank the speakers. So I guess I'm going to thank myself, if you don't mind. On a serious note, thank you, Hilmi. Thank you, Isneen. And thank you, Jill, a speaker and my co-chair. Thoroughly enjoy doing this with you. And also I'd like to thank the Gestel Foundation, of course, as well as the New Mexico, Sajif Aurora, for this wonderful program that he's offered to us, and the ECHO team in India that is always behind the scenes helping us with everything, the logistics. Thank you to Karen and Cheryl. We really appreciate you guys. Please do fill in the feedback form, which is posted in the chat. Just to remind you that all these topics that have been covered since we started, you will find them on the foundation website. And then I'd love to thank the sponsors without whom we cannot operate or function. You will see that it is posted that the next offering is going to be on patient blood management. I urge you to please attend. Let's support all the programs within our GECO family. On that note, thank you and have a good evening.
Thanks a lot.
Cheers, everyone. Bye.